Hello, everyone, and welcome to this INI-CET November 2025 recall anatomy part. I'm Dr. Ashwini Kumar, and I'll be taking care of the anatomy questions for you. Uh, just like a typical INI-CET paper, well, there's no surprises in this as well. The May INI-CET and even the last year, the dominant part of the INI-CET has always been the neuroanatomy and the head and neck portion. And then subsequently, if you go to the next rest of the topics, like they generally ask just only a couple of questions from that region. So let's have a very quick analysis of what questions are asked from what topics, and then we'll proceed with the questions. And you can see that I've just made a little table here to give you a little insight about how many questions are asked from the different areas. Clearly, the head, neck, and face is the one which is topping the list. There were 5 questions from the head, neck, and face itself. Followed by neuroanatomy, there were 4 questions. So imagine total 14 questions were asked this time from the anatomy, and 9 of them were from the head, neck, and neuroanatomy itself. So clearly tells you that how much neuro and the head, neck, and face dominates in the INI-CET part. And for that matter, in NEET also nowadays, I mean, there's not much of a difference left between the NEET and INI-CET level of questions, especially when it comes to the anatomy part. Embryology, if you look at, there's one question from embryology, a little on a surprising side, because embryology, they usually ask like 2 to 3 questions from that. So there was one question from the embryology, but there was no surprise in what question was asked, because there's cardiovascular embryology has always been their favorite. So again, there was a question from the CVS embryology, and that was one question from embryo. There are 2 questions from the lower limb, and both questions were more like osteology based questions. Like that's what they are switching to. The major bony prominences and all that. So in lower limb, in last few years, we have seen that a lot of questions from the muscle attachment, the muscles and the bone, especially hip bone. The area around the hip bone is usually the end sacrum as one of their favorite part to ask. One question from the upper limb, it was more of an ortho based question actually. And again, nothing from thorax, nothing from abdomen, pelvis, and no question from general anatomy. Please understand, I'm not saying that thorax, abdomen, and general anatomy is not important at all. I would say general anatomy probably is not, because number of questions are 200. So I don't think the examiner is going to waste their questions by asking a question on general anatomy as such. So, but thorax and abdomen, they do ask questions thorax and abdomen, and sometimes the number of questions from thorax and abdomen can go up to 2 to 4 as well, like collectively. But having said that, still head, neck, and face, neuroanatomy, and embryology was, and probably will be the dominating part in the INI-CET. Having said that, let's start with the questions. So, guys, let us start with the HNF questions first. The neuroanatomy questions, in fact. So, the first question you're looking at, it says that match the following to the corresponding labels in the image. I always say this whenever there is an image-based question asked, people think that image-based questions are difficult. Actually, image-based questions are easier than the normal with the questions without images. The reason being, when they give an image of a particular thing, then I've generally seen their focus is to ask you to identify the structure and nothing beyond it. So they rarely will make a complicated question out of an image base. So generally they will put an arrow at certain places on the brain, on the brain stem, or any part, and they will ask you, okay, identify the mark structure. And same is in here. So they have put 4 arrows there, and they've asked that what are the structures you need to identify them. And as a typical INI-CET pattern, they will give you like multiple options. It's like more like a match the following, so that if you miss out on any one of those arrows, then you probably will end up answering it incorrectly. So let's have a quick discussion on this image, and then we'll go to the options. Okay. So guys, when you look at the dorsal aspect of the brainstem, let's start like even above the brainstem. What you're looking at over there, look at the arrows, that there's a thalamus there. And the two thalamus, the occupying between the two thalamus is a third ventricle. You can see there's a third ventricle between the two thalamus, and just behind the thalamus there is metathalamus, that the two geniculate bodies can be seen. There is a medial geniculate body and the lateral geniculate body. You also can see there is a pineal gland shown over there. The pineal gland, which is going to form the posterior wall of the third ventricle, well, can be better appreciated in the sagittal section, but just to tell you, it forms the posterior wall of the third ventricle, can be seen. And now if I go further below that, you will be able to see the midbrain. And as we all know that the midbrain section is taken at 2 different levels, one at the level of superior colliculus and another one is taken at the level of inferior colliculus. The third nerve nucleus is present at the level of superior colliculus, and the fourth nucleus is present at the level of inferior colliculus. And just below the colliculus, below this corpora quadrigemina, you can see the only cranial nerve which is to be seen coming out from the dorsal aspect of the brainstem. Well, that's the trochlear nerve, or fourth nerve, can be seen. Now we go further below the midbrain. You're looking at the pons. It's the pons area, and even the open part of medulla oblongata can be seen. Fourth ventricle is facing towards the pons and also toward the open part of the medulla oblongata. So what do you see in the boundaries? Now it's important to understand when you look at the fourth ventricle, the floor of fourth ventricle is also called as a rhomboid fossa because of its rhombus shape. The two superior peduncle will be converging downward from the midbrain, and the inferior peduncle will go above from the medulla oblongata. If you look at this picture, look at this peduncle here, the cut section of the superior cerebellar peduncle, which is converging downward, and that's the inferior cerebellar peduncle, which is converging upward. And both these peduncles are joining with each other. So that's why in the boundary of the fourth ventricle, the superior and the inferior cerebellar peduncle plays a role, whereas the middle cerebellar peduncle is lying more outside. Look at the middle cerebellar peduncle is like present more outside. That's a middle cerebellar peduncle like outside. So if you're looking at the which peduncle is which one, look at the two peduncle converging toward each other, and they are contributing to the boundary of the fourth ventricle, that is superior and the inferior. And in between, the one which is more outside is a middle cerebellar peduncle. Let me go further below. We're looking at the dorsal aspect of the brainstem, so why not discuss other things as well? Now, this over here, this is the area of the medulla oblongata. That's a lower part of the medulla oblongata you're looking at. And in continuity with the spinal cord, the fasciculus gracilis and fasciculus cuneatus are going to land into the nucleus present over there. This is where the nucleus gracilis is present. This is where nucleus cuneatus is present. And these two tubercle-like structures are called as a gracile tubercle and cuneate tubercle. We call them gracile tubercle because the nucleus gracilis is present deep to it. And we call it a cuneate tubercle because nucleus cuneatus is present deep to it here. Inside the floor of the fourth ventricle, the four major elevations which we always talk about, and one of the favorite questions, which always have been one of the favorite questions for the INI-CET, is about the facial colliculus. That elevation that you see in the floor of the fourth ventricle, that big elevation, there is a facial colliculus, which is found by the lower motor neurons of the facial nerve winding around the abducens nucleus. So the nucleus lying deep to the facial colliculus is abducens, but obviously it's the facial nerve fibers which are winding around it. So that's a facial colliculus. Just below facial colliculus, you can see there is a hypoglossal triangle. Hypoglossal nucleus is present deep to it. And further below that, we have a dorsal nucleus of vagus. And that's why the triangle is called as a vagal triangle. Vagal triangle, vagal trigone, vagal prominence, whatever you can call it. So it's facial colliculus. We have hypoglossal triangle and vagal triangle. And all these motor nuclei are present medial to the sulcus, which is called as sulcus limitans. Now look at the pointer on the screen. This is where the sulcus limitans is present. Outside the sulcus limitans, this big triangle that you see over there, this is the one occupying the vestibular nuclei, and that's why we call it a vestibular triangle. So these are some important things that you should be able to identify from the dorsal aspect of the brainstem. And look at the highlighted one, the inferior colliculus, superior, middle, inferior cerebellar peduncle, were probably the one which were asked in the exam. So let me fall back to the question. It says match the following to the corresponding labels in the image. So number one over there is the inferior colliculus. Number two is the superior cerebellar peduncle, which is converging downward. Number three is a middle cerebellar peduncle, more outside. The peduncle of the pons is more outside. And then we have the one which is converging from below upward. That is the inferior cerebellar peduncle. So from the given option, option A is the correct answer, which is showing you the correct match. So that was one question from the dorsal aspect of the brainstem. Moving on, the next question, it's a sagittal section of the brain was given. And it says the marked structure forms the medial wall of which of the following. Now, again, you can see, as I told you before the previous question also, that generally when they put an arrow on something, it's very basic. They are simply asking what you're looking at. I mean, I'm pretty sure that you are aware of this, that sections of brain is something you cannot leave it, like sagittal, transverse, coronal section, something or the other, they will ask you like every year or every alternate year, there will be at least one question on this. So when you look at the sagittal section of the brain, guys, first of all, please look at the corpus callosum. Now here is the corpus callosum you're looking at. That's a genu part of the corpus callosum. We have a rostrum here. This is the body. And you can see that's the thickest portion of the posterior most part of the corpus callosum. That is the splenium. I hope you can even appreciate a little band-like structure present below the corpus callosum here. That is the fornix. Now they have always been asked, the question were asked on the fornix in the earlier exam also. Fornix is a white matter bundle which originates from the hippocampus, and then it goes upward, forward, and downward and terminates in mammillary body. Mammillary body, which is present somewhere here, that is a mammillary body. So this is where the fornix fibers are going to terminate, in the mammillary body. This originates in hippocampus, that terminates in mammillary body. And just below the fornix, you are saying that highlighted area over there is the third ventricle. So third ventricle, fornix is forming the boundary for the third ventricle. But the question is on something which is stretching between the corpus callosum and the fornix, and that structure which was asked in the exam is the septum pellucidum, guys. Septum, you know what is septum? Pellucidum is translucent. It's a translucent septum which is present between the two lateral ventricles, that is septum pellucidum. So the mark structure is septum pellucidum, but they asked that what this septum pellucidum is separating. Now, you can already see third ventricle is present below the fornix. So obviously, what ventricle do I expect to see above the third ventricle present in both the cerebrum? And that is the lateral ventricle. Now, I wanted to, whenever you look at a section, guys, you should be able to correlate the sagittal section with the transverse, with the coronal section. Now, imagine if I take a coronal section, like along this arrow, look at this dotted line there. So you can see in this sagittal section, that we're going to take, it should be visible the corpus callosum, followed by the septum pellucidum, followed by the fornix, and then followed by the third ventricle should be seen in that image. Now here we go. Look at this coronal section. Now you can see the first thing you're looking at over there is a corpus callosum. Below you can see there is a fornix, and further below the fornix, I hope you can see the third ventricle. That cavity over there is a third ventricle. And as we can see over there, that between the corpus callosum and the fornix, that septum which is stretching, look at that septum over there. This is the septum pellucidum, and the job of septum pellucidum is to separate the two lateral ventricles. You can see the cavities of the two lateral ventricles there. That's a third ventricle, and these are the two lateral ventricles, the body of the lateral ventricle, which can be appreciated better in the coronal section. And that's what exactly the question was asked, that the mark structure separates what? So if I go back to the question again, it says that what are the structures which are separated by the mark structure? Well, that is septum pellucidum separating the two lateral ventricle from each other. The next question we have is, a patient presents with a drooping of the eyelid, meiosis, and anhidrosis. A diagnosis of Horner syndrome is made. Where is the lesion most likely located? Now, I would say this is a little tricky question. Two of the options are very easy to eliminate in this, and there's a fight between the two options in this here. I wanted to understand this concept, guys. Now, they could have simply said it's a diagnosis of Horner syndrome is made, but they've given the three major features, that the drooping of the eyelid, the meiosis, and anhidrosis is mentioned. That means the patient is not having like only eyelids are drooped or only meiosis is there. All three are there. Eyelid is drooped, meiosis is there, and there is an anhidrosis also. So the question is, where is the most likely lesion is located? I'm pretty sure that everyone is able to eliminate the option A and C from this. A is intercostobrachial nerve. Intercostobrachial nerve, it's a branch of T2 nerve. The second intercostal nerve gives off a branch, and that branch of the second intercostal nerve supplies the skin of the axilla and the medial side of arm. So we call it an intercostobrachial. So that nerve has nothing to do with the sympathetic outflow. So intercostobrachial nerve is just a cutaneous nerve. Similarly, abducens nerve, guys, if there is an injury to abducens nerve, we all know that lateral rectus muscle will not work and there will be convergent squint. And again, that has nothing to do with the Horner syndrome. So it's about, is the option the cervical sympathetic chain, or is it the sympathetic plexus around the internal carotid artery? Now, if you remember this question, fine. If you don't, I wanted to just, before I start with the explanation, I wanted to just analyze in your head that the three features are given: drooping of the eyelid, meiosis, and anhidrosis. Is cervical sympathetic chain a better answer, or the sympathetic plexus around internal carotid artery is a better answer? Okay, let's understand this. Now, you're looking at a section of a spinal cord. Now, we know the highest center for the autonomic nervous system, the sympathetic outflow, is hypothalamus. The first order neuron for the sympathetic outflow will start from the hypothalamus. So let's say from the hypothalamus, the first order neurons will come, and they are going to stimulate the lateral horn of the spinal cord. Now, lateral horn of the spinal cord exists where the sympathetic outflow is present, T1 to L2. Sympathetic outflow is thoracolumbar outflow. So from T1 to L2, that's a part of the spinal cord where we will see the lateral horn. So these fibers from the hypothalamus, the first order neuron from hypothalamus, are going to stimulate those cell bodies present in the lateral horn of the spinal cord. Let us say this is a sympathetic chain. Now, you know, sympathetic chain is extending into the neck region also. The second order neuron starting from the lateral horn of the spinal cord will go into the first thoracic sympathetic ganglion, the T1 ganglion, guys. I mean, sympathetic chain is extending above T1 also. So the second order neurons are going to enter into the sympathetic chain at the level of T1, and the same second order neuron will ascend upward to reach the superior cervical ganglion. As you can see, there is an inferior cervical ganglion, the middle cervical, and that is a superior cervical ganglion. And this is where the second order neurons are going to reach. So first order neurons are coming from hypothalamus to the spinal cord. from the spinal cord into the sympathetic chain, ascending into the sympathetic chain till the superior cervical ganglion. We have a second order neuron for the sympathetic nervous system, sympathetic pathway. The third order neurons from the superior cervical ganglion will go out, and some of them will make a plexus around the internal carotid artery. You can see there's a sympathetic plexus present around the internal carotid artery, and the fibers from the sympathetic plexus around internal carotid artery are going to supply the muscles like dilator pupillae muscles and the Muller's muscle, that is a superior tarsus muscle. That is about the sympathetic plexus which is present around the internal carotid artery. But here's the catch. We also have the sympathetic plexus present around the external carotid artery also. So we have another set of third order neurons which are coming from superior cervical ganglion, and they are making the sympathetic plexus around external carotid artery, which are mainly going to supply which are cutaneous vasomotor and also supplying the sweat gland of the face. Majority of the sweat gland of the face, especially like below the forehead region, they are supplied by the sympathetic plexus present around the external carotid artery. Now imagine if there is an injury at the level of the sympathetic plexus around internal carotid artery, like that, like you can see in this animation, then in that case, obviously the dilator pupillae and the superior tarsal muscle will not work, so patient will have the meiosis and ptosis. And if there is an injury to the sympathetic plexus around the external carotid artery, in that case, there will be anhidrosis, because most of the sweat glands are supplied by the sympathetic plexus around the external carotid artery. And because the question specifically mentioned that there is meiosis, ptosis, and anhidrosis also, so having an injury to any one of the sympathetic plexus will not give you all the four features, all the three features. To have meiosis, ptosis, and anhidrosis, rather than choosing the answer sympathetic plexus around internal carotid artery, you have to go with the sympathetic chain. So if there is an injury to the superior cervical ganglion or to the cervical sympathetic chain, then you will see all the features of the meiosis, ptosis, and anhidrosis also. That is why from the given options, the best answer is the cervical sympathetic chain, not the sympathetic plexus around the internal carotid artery. So though it was a simple question, but this terminology made all the difference here. Even, I mean, sometimes you probably, when you look at that question, you must have wondered when they're saying the Horner syndrome diagnosis is made, then why they have given the features. They have given the features to make sure to give you the information that all the three things are seen, and it's not just the ptosis or meiosis history. Even anhidrosis can also be appreciated in that patient. Moving on to the next question, guys. Another question from this that's neuro is which of the following areas responsible for the scanning of the visual field? Now, the question is asked about the scanning of the visual field, and probably the question was not about that which is the visual cortex. That's one of the reasons that the option D is mentioned there, because option D, we know that that's a visual cortex, that's occipital lobe which is given over there. Let's have a little analysis on the four A, B, C, D options which were given in the exam. Now, if this is a lateral view of the cerebral hemisphere, you can see that area A, which is marked over there, that is a middle frontal gyrus. That's a middle frontal gyrus you're looking at. It's a middle posterior part of the middle frontal gyrus you're looking at. This sulcus here is the central sulcus. Look at my pointer here. That is the central sulcus. And this area which is present in front of the central sulcus, that is a pre-central gyrus. Then looking at the occipital lobe around the calcarine sulcus, that is the occipital lobe, and that's the area around the calcarine sulcus we're looking at. And here is the superior temporal gyrus. It's a temporal lobe, and that's a superior temporal gyrus we're looking at. Now, as we know that superior temporal gyrus, we have the Brodmann's area number 41 and 42 present over there, and Brodmann number area 141, 42 is the auditory area. It's a primary auditory area, so hearing perception will go into that. Area marked as D is the occipital lobe around the calcarine sulcus, and your primary visual cortex is the one which is winding around this calcarine sulcus, area number 17, 18, and 19, especially the area number 17, which is a primary visual cortex for the visual perception. The precentral gyrus, the one which is in front of the central sulcus, is area number 4, and we know that area number 4 is a primary motor cortex which is controlling the opposite half of the body. The voluntary control of the opposite half of the body is by the primary motor cortex, which is present in front of the central sulcus. And there comes the posterior part of middle frontal gyrus, where we have area number 8 called as a frontal eye field area, and the frontal eye field area is responsible for the scanning ocular activity. The scanning movement of the eyeball to gauge whatever is there in the visual field is the function of this area number 8, and this area is not dependent on the visual stimulus. I mean, you need not have a visual stimulus for this area to work and gauge whatever is there in your visual field. So scanning of the visual field is done by the area number 8, which is present in the middle frontal gyrus, and not by the one in the occipital lobe. Occipital lobe is a primary visual cortex. It is to see. It is to see. To see, and then area number 18 and 19 is to understand what you're looking at. But scanning of the visual field is done by the area number 8. That is also for the conjugate voluntary eye movement. So again, for the given question, the area responsible for the scanning of the visual field, the answer is option A, that is a middle frontal gyrus. Moving on to the next question, now coming to some of the questions on head and neck, and again, the couple of osteology question you can see there. Now, I'm pretty sure that the moment you look at this image, you must have seen these questions earlier also. This is a question, I would say, probably third time they have given the picture of this, the first cervical vertebrae. The atlas vertebrae is given. But you know what is important in this, and they probably can play this trick next time. What view of the atlas is this? Is this a superior view of the atlas, or is it the inferior view of the atlas? So let's have a little discussion on this image first. Now, if you look at the atlas vertebrae here, it is a superior view of the atlas. Now, how can I say it is a superior view of the atlas? It is the articular facet. Now, look at those articular facet over there. They're more elliptical. They're not rounded. They're more elliptical in shape. If you see these superior articular facet, they're more elliptical in shape. They're definitely looking at the superior view of the atlas vertebrae. How atlas vertebrae is different from the other cervical vertebrae? The one thing which is missing in the atlas vertebrae or the C1 vertebrae is body. There's no centrum. There is no body in it. Now, instead of the body, there is the anterior arch of the atlas, and there's a posterior arch of the atlas. So we have the two arches, anterior arch and the posterior arch of the atlas. And again, it's not difficult to identify which one is anterior, which is posterior. As you can see, the anterior arch of the atlas is short and the posterior arch is longer. You can see this anterior arch, it's a shorter arch, and the longer arch is a posterior arch, which will give an orientation that what is the anterior posterior of this image. And by looking at the facet, you can make out what is superior and inferior. Anterior arch of the atlas is having a little tubercle on there, which is called as the anterior tubercle. And also, there is another important feature, that is posterior tubercle is a feature of the posterior arch of the atlas. There's another feature of the anterior arch of the atlas, that there is a facet which is present just on the posterior side of this anterior arch, and that is a facet for the dens. Facet for the dens. So let us say if the arrow was placed somewhere here, like just behind the anterior arch of the atlas, then it is the area where the dens is articulating, and that is making the joint the atlantoaxial joint. The median atlantoaxial joint, which is responsible for this noding movement. When you say no to someone like this, that is occurring at the atlantoaxial joint, and that joint is forming at that point, just behind the anterior arch of the atlas. Another very important feature of the posterior arch of the atlas is the presence of a groove. Can you see a little shallow groove is present on the superior surface of the posterior arch of the atlas, and that is a groove for the vertebral artery. The third part of the vertebral artery is running on it. So when the vertebral artery comes out of this foramen, which is another typical feature of the cervical vertebrae having a foramen transversarium, once the vertebral artery comes out of the foramen transversarium, it runs on this posterior arch of the atlas, and then it goes into the foramen magnum to become the fourth part here. That's the third part of the vertebral artery that will be seen running on this groove, which is present over the posterior arch of the atlas. And coming to the area which was marked in the exam, well, this was a superior articular facet which was shown. And superior articular facet, obviously, what is above the atlas vertebrae is the occipital bone. Occipital condyles will articulate with it, and that will form an atlanto-occipital joint. So it articulates with the occipital condyle, and that makes an atlanto-occipital joint. The joint which is responsible for this movement, this noding movement of saying yes, that is done at the atlanto-occipital joint. So if they've asked you about this articular facet, well, we won't be surprised that next time they might ask you this facet which is present behind the anterior arch, which is for the articulation with the axis to form the median atlantoaxial joint. But there could be one more catch in this question, guys. Let us say if they give you the first cervical vertebrae, but not from the superior view. I guess they've already asked this image 3 times in the exam, and every time it's a superior view of the atlas which is given. But let's look at the atlas vertebrae from the inferior aspect. It looks more or less the same. If both the images, they look kind of same only. But look at this superior articular facet, which is more elliptical when you see it from the superior aspect. But when you see from the inferior aspect, it is more oval, it is more rounded. And that tells you it is an inferior view of the atlas vertebrae. And in the inferior of the atlas vertebrae, that articular facet that you're looking at, It is for the articulation with the superior articular facet of the axis vertebrae or the second cervical vertebrae. So if the arrow was placed, which was in the question, on the superior articular facet, then obviously occipital condyle is articulating with it. If it is on the inferior articular facet of the atlas vertebrae, that is going to articulate with the superior articular facet of the second cervical vertebrae, that is axis. So yes, guys, for this particular question, for this particular marked area, occipital bone or occipital condyle is the right answer. Moving on to the next question, another osteology question which was asked, that which of the following bone contains a cranial nerve related directly to the CNS? The keyword is directly related to CNS, guys. Now, when you think of the cranial nerves, third nerve onward, they're all coming from brainstem. And these are they're typical nerves, they're like peripheral nerves. But when you look at the first nerve and second nerve, they're more like the extension of the brain only. Like olfactory nerve, it goes directly into the olfactory bulb. It's more like an extension of the telencephalon, and the optic nerve is an extension of the diencephalon, right? So the first and second nerve are the one which are extension of the brain directly. If I put this picture once again, look at the four bones, guys. What is the first bone you're looking at in the option A? Bone A, I'm sure you must have seen this bone many times in your ENT discussion. That's a temporal bone you're looking at. That's a lateral view of the temporal bone. And when you think of that, what are the openings present in the temporal bone? There is an internal acoustic meatus which is present here. When you see the temporal bone from the superior aspect, from the cranial cavity view, you will see there is an internal acoustic meatus present in it. And internal acoustic meatus will give passage to the seventh and eighth nerve. Seventh and eighth nerve will be going through this internal acoustic meatus. So obviously, they are the peripheral nerves only. They are not. They're not like the extension of the brain. So A cannot be the answer to this question. The second bone you're looking at, it's a side view of the zygomatic bone. You're looking at a zygomatic bone, and on the zygomatic bone, I hope you can appreciate the foramen present over there. This foramen here on the zygomatic bone is called a zygomatic foramen, and this is giving passage to the nerve called as zygomaticofacial nerve. Zygomaticofacial nerve is a branch of maxillary nerve only. Zygomaticofacial nerve is a branch of maxillary nerve. It's a small sensory nerve supplying the skin in this area. So again, because it's a branch of maxillary nerve, so it does not qualify to be called as a direct extension of the brain. C, that is the maxilla bone given over there. That was zygomatic. This is a maxilla bone, and you can again appreciate a foramen present on the maxilla, present just below the orbit. That is an infraorbital foramen, and this infraorbital foramen is giving passage to the infraorbital nerve, which is again an extension of the maxillary nerve only. Infraorbital nerve is also an extension of the maxillary nerve itself. And finally, then we have this fourth bone which is given. It's a view from the front of the ethmoid bone. Now it's an ethmoid bone. You can see that's a perpendicular plate of the ethmoid bone. You can see the superior and the middle concha of the nose will be found by the ethmoid bone only. You can clearly see the ethmoidal air sinuses to be seen on both the side. Even this projection, which is called as a crista galli, can also be seen in there. And I'm sure that you must have seen this ethmoid bone from the cranial fossa also. And there is a plate present in the ethmoid bone called as a cribriform plate. And that cribriform plate gives passage to the olfactory nerves or olfactory axons. And olfactory nerve is a direct extension of the telencephalon or the central nervous system. So if these four bones were given in the option, the ethmoid bone is the right answer because it is giving passage to the olfactory nerve. If I add sphenoid bone also in the option, guys, let's say if I just add fourth option as a sphenoid bone, even sphenoid bone is also correct because sphenoid bone is also giving passage to optic nerve, and optic canal is a part of the sphenoid bone only, and that is again the extension of the brain. Now let's say if you have an impossible choice of choosing one between the ethmoid bone and sphenoid bone, both are giving passage to the one to the first nerve, one to the second nerve, and both are the extension of brain only, but you still have to choose between the ethmoid and the sphenoid bone. Go with the ethmoid bone because cribriform plate is something which is present in the ethmoid bone itself. Optic canal present in the sphenoid bone is present between the lesser wing of the sphenoid and the body of the sphenoid. So it is between the two part of the sphenoid bone we have the optic canal, which is giving passage to the optic nerve. Because the question says that which of the following bone contains the cranial nerve related direct to CNS. So definitely the better answer would have been the ethmoid bone from the given option. Even if the sphenoid bone is in the option, ethmoid bone definitely will be the better answer for this question. Moving to the next question, guys, it is a sagittal section, a cadaveric sagittal section was given, and based on the recall, probably these are the arrow mark structure given in the exam. Maybe could be a little different also, doesn't matter. I mean, we need to identify what we're looking at, and based on that we'll analyze the question. It says which of the following is not involved in either dysarthria or dysphagia. A little tricky one again, because the question is not only about the dysphagia, it's like which of the following muscle is neither have a role to play in dysphagia and dysarthria also. So we have to eliminate both the option for the muscles which are marked in this. In the sagittal section, guys, I hope you can appreciate the three nasal concha there, the superior and middle inferior nasal concha, and just behind the inferior nasal concha, this is where we have the opening for the eustachian tube, right? That's where we have opening eustachian tube. You can see one fold in front of the eustachian tube, one fold behind the eustachian tube, and then you can see one more muscle which is to be seen more in the deeper aspect when you see from the medial side. And few muscle, one palate muscle was mentioned, one muscle which is a pharyngeal constrictor was pointed out, and one tongue muscle is also given in this image. How about we identify all the possible muscle that we can see in this section? Now, if you look at that, we said that is the fold which is present. Like if there's the opening for the eustachian tube, you can see the fold which is going toward the palate. This fold is holding the muscle that is levator vellae palatini, and there is a fold which is extending from this opening of the eustachian tube toward the pharynx, which is holding the muscle that is a salpingopharyngeus. So levator vellae palatini muscle is present deep to this fold, and salpingopharyngeus is present like here from here. And we know that all the longitudinal muscle of pharynx, salpingopharyngeus, stylopharyngeus, palatopharyngeus, all these muscles are going to insert on the posterior border of the thyroid cartilage. They all insert onto the posterior lamina of the thyroid cartilage. So if in the question any of the pharyngeal muscle is given, salpingo, palatos, or the stylopharyngeus muscle, any longitudinal muscle of pharynx is given, well, that has a role to play in, obviously, in the deglutition, in the dysphagia. And because they're pulling the thyroid cartilage upward, which is a laryngeal cartilage, so they have a role to play, maybe mild role, maybe moderate role, or major role to play in dysarthria also. The muscle which is present, like obviously when you see from this lateral aspect, it's more superficially placed muscle, but when you see from this side, from the medial aspect, it's more deeply placed muscle, more anterior and more deeply placed to the eustachian tube. That is a tensor vellae palatini muscle. And based on the recall, they said that this was one of the muscle given in the option. That is a tensor vellae palatini. The another muscle which is shown over there is the muscle constrictor, guys. I mean, when you look at the longitudinal muscle, apart from longitudinal muscle, the outer muscles in the pharynx are constrictor. Like somewhere at this level, we have a superior constrictor, then we have middle constrictor, then we have inferior constrictor. Let's say simply constrictor muscles, which are the outer muscles in the pharyngeal wall, are also mentioned. You can also see a muscle which is, there's a muscle, if you look at the palate, there is a palatine tonsil present below that. So we have one fold going called as a palatoglossal fold, one is a palatopharyngeal fold. So deep to the palatoglossal fold, obviously palatoglossus muscle is present, and deep to the palatopharyngeal fold, palatopharyngeus muscle is present. Again, probably the muscle which was given in the exam was a palatopharyngeus muscle. And you can even see this, one of the most important muscle of the tongue, which is shown over there, coming from the genial tubercle, the superior genial tubercle of the mandible. That is the genioglossus muscle. That muscle is genioglossus, the fan-shaped muscle, the one of the major muscle of the tongue, the genioglossus. So again, as I said, based on the best of the recall, that the tensor vellae palatini, palatopharyngeus, genioglossus, and constrictor, the superior constrictor muscle, probably were given in the exam. And the question was that which of these muscles have no role to play, like they're not involved either in dysphagia or dysarthria. Let's have a little analysis of all these muscles. Now, we already know the four muscles. Now, guys, let me start with the superior constrictor first. Now, we all know that superior constrictor is responsible for the narrowing of the pharynx. And the upper border of the superior constrictor, the fibers of the palatopharyngeus muscles are merging with it to form the pachymenes ridge. So that also is responsible. That is not only for the peristalsis. This is also the velopharyngeal, the pharyngeal closure is also done by this muscle, by this pachymenes ridge. So it has to role a play in speech also. So that's why superior constrictor muscle, definitely it has a constrictor muscle, it's a pharyngeal muscle, it has a role to play in the deglutition. But because along with the palatopharyngeus muscle, it is forming the pachymenes ridge, which is constricting the passage between the soft palate and the pharynx. So it has a role to play in the articulation as well. The genioglossus muscle, the major muscle of the tongue, well, it is a muscle which protrudes the tongue and even stabilizes the tongue. The genioglossus muscle is responsible for, it helps in the deglutition, and it also helps in the articulation of certain words. So if the genioglossus muscle is involved, there will be a dysphagia to an extent. and there will be difficulty in articulation as well. Palatopharyngeus muscle, the muscle palatopharyngeus, I told you any longitudinal muscle is going to insert on the posterior border of thyroid cartilage. If it is inserting onto the posterior border of thyroid cartilage, these muscle contractions are going to lift the thyroid cartilage up. Lifting the thyroid cartilage upwards, that obviously will have the effect on the speech as well. So again, the palatopharyngeus muscle, it definitely has to do with, it's a pharyngeal muscle, so it is for to elevate the pharynx. It has a responsibility in the movement of the bolus, but it is also have a role to play in articulation as well. And there comes the fourth option, that is a tensor veli palatini muscle. Now, tensor veli palatini muscle, it tenses the palate. The tensing, this muscle has not much of a role to play in the deglutition, maybe a little role to play in the speech, because if this muscle is involved, there could be a little hypernasality in the speech. A little hypernasality in the speech will be seen, and not much of a change. So out of the given four options, the tensor veli palatini muscle is the one which is neither involved, like it does not have a much role to play in the dysphagia as well as in dysarthria. So from this given option, the tensor veli palatini would be the best answer. That is option A, the one that is the tensor veli palatini muscle. Moving on to the next question, guys, that is again one of their favorite question area to be asked from, and we keep talking about this in the revision videos, in our main videos also, that in head, neck and face, something that you cannot miss out on ever is the muscles of mastication and temporomandibular joint, because directly or indirectly they are going to ask you a question on that. The question says a woman has a difficulty opening her mouth but no problem in closing it. Which of the following is true about the muscle affected in the condition? So the first statement given is for you to identify what muscle they are talking about, and then you need to know some anatomical detail of that muscle also. Now, I'm pretty sure that most of you have had no difficulty in identifying what muscle they're talking about, because the only muscle from the muscle of mastication, I'm talking about the four muscle of mastication. Out of the four muscle of mastication, the only muscle which is responsible for the opening of the mouth or the depression of the jaw is lateral pterygoid. So the question is on the lateral pterygoid muscle. Medial pterygoid, masseter, and temporalis muscle, all the three muscles, they assist in the closing of the mouth. Only muscle for the opening of mouth is a lateral pterygoid muscle. And then we need to see some of the features of the lateral pterygoid and which of the following are matching or not matching to the lateral pterygoid. Typical INI-CET question again, match the muscle with the corresponding options. So, guys, look at this picture. It's a lateral view of the muscle of mastication. The lateral pterygoid and medial pterygoid muscles are to be seen there. Now, our focus is on this lateral pterygoid. The origin of the lateral pterygoid muscle is from the lateral surface of lateral pterygoid plate. Now, this is something very important, that the two pterygoid muscles, the lateral pterygoid as well as medial pterygoid muscle, they both will originate from lateral pterygoid plate only. Lateral pterygoid is from the lateral surface of lateral pterygoid plate. Medial pterygoid is from the medial surface of lateral pterygoid plate. So remember, medial pterygoid plate is not giving origin to pterygoid muscle. It's the lateral pterygoid plate which is going to give origin to the lateral pterygoid from the lateral surface, and medial pterygoid from medial surface. We have other origin also, like the lateral pterygoid plate is not the only origin for the lateral pterygoid. It is also originating from a crest which is present on the greater wing of the sphenoid also. But again, going to the basic portion, it's a lateral surface of lateral pterygoid plate which is giving origin to lateral pterygoid muscle. Then you can see the muscle is running horizontally backwards, and the muscle is inserted onto the neck of mandible. There's a depression on the neck of mandible which is called as a pterygoid fovea. Fovea is a small depression, and it is also inserted to the capsule of the TMJ. The muscle is inserted onto a small depression in front of the neck of the mandible, that is pterygoid fovea, and also to the capsule of the TMJ. So clearly one of the muscle of mastication which is inserted very close to the TMJ, in fact on the capsule of the TMJ itself, is the lateral pterygoid muscle. There is one more very important feature of this muscle which I'm sure you all must have read about this. This is the articular disc. The articular disc is a fibrocartilage which is present inside the cavity of TMJ, and this articular disc is an extension of tendon of lateral pterygoid only. That is also one of the PYQ. So lateral pterygoid tendon, it is inserted to the capsule, and then you see there is a morphological remnant or the extension of this lateral pterygoid inside the cavity of TMJ, and that is the articular disc. This fibrocartilage inside is the articular disc. Talking about the action of the lateral pterygoid, because the muscle is oriented backwards, horizontally backward, so this muscle is responsible for the protrusion. Protrusion can be done by the medial pterygoid and masseter muscle also, but they are not the major protruder. This is the main protruder. If the question is asked which muscle is the main protruder, again lateral pterygoid is the answer. And it is the only muscle of mastication which can depress the mandible or help in the opening of the mouth. So this also helps in the depression as well. So protrusion and depression is the function, and depression is a unique function because temporalis, masseter, and medial pterygoid, I told you these muscles are not going to cause the depression, they cause elevation. So that's the only muscle which can open the mouth. All remaining three muscles will help in the closing of the mouth. So muscle is inserted close to the joint. It is responsible for the opening of the mandible. It is originating from the lateral pterygoid plate. Extension of the muscle inside the cavity of TMJ is articular disc. And I hope you know that all the muscle of mastications are supplied by the mandibular nerve. But and yet another INI-CET question, guys. Medial pterygoid is the only muscle of mastication which is supplied by the trunk of the mandibular nerve. Remaining all muscles are supplied by the anterior division of the mandibular nerve. So that's again an important point to remember, that all the muscle of mastication, medial, the lateral pterygoid, this one, masseter, and temporalis, they are all supplied by the anterior division of mandibular nerve. The only muscle of mastication which is supplied by mandibular nerve only, but not by the division, but by the trunk of the mandibular nerve, is medial pterygoid, right? So if I go back to the options again, we already know the muscle they're talking about is lateral pterygoid. Now, which of the options are correct in here? The muscle attaches to the close to the temporomandibular joint. Yes, it is correct. The muscle depresses the mandible. That is correct as well. It is attached to the medial pterygoid plate is not correct. Even the medial pterygoid muscle is not attached to medial pterygoid plate. So that is not correct here. And option 4 is correct as well. The muscle is supplied by the mandibular nerve, more precisely by the anterior division of mandibular nerve. So option 1, 2, and 4 for this particular question are the correct option to choose. That was the question on the lateral pterygoid. Moving on, yet another question from head and neck, and that is again like toward the osteology part, the question on the osteology. The question was pretty simple. Through which of the following foramina does the nerve supplying the muscle of mastication passes? We just talked about the nerve. The nerve supplying the muscle of mastication is the mandibular nerve. We just need to find out mandibular nerve is running through which of the following foramen. Well, they've asked the better, or I would say a little more complicated questions on the skull osteology earlier in the exam. It was pretty simple. Now, the 4 foramen which were given in the exam is the one is this, which is present just medial to this anterior clinoid process, and that is the optic canal. You can see that is the optic canal. The another opening that is given in the exam is this one, which is an oval foramen called as a foramen ovale, located in the greater wing of the sphenoid, that is foramen ovale. Then when you see which is present between the petrous part of the temporal bone and the occipital bone, that another important foramen is the jugular foramen. And there is a foramen present in the occipital bone, more anterolateral to the foramen magnum, that is the hypoglossal canal. So optic canal, foramen ovale, jugular foramen, hypoglossal canal are given in the option. Optic canal is giving passage to the optic nerve and ophthalmic artery. So when optic nerve is going to pass through it, an ophthalmic artery also. Foramen ovale, I'm pretty sure you all know this famous mnemonic, male is passing through this foramen ovale, and male is M is the mandibular nerve. A is accessory meningeal artery, which is a branch of the maxillary artery only. The lesser petrosal nerve, which is coming from the tympanic plexus, and emissary vein. They're going from foramen ovale, male structures. Mandibular nerve is going from foramen ovale itself. Jugular foramen is giving passage to the 2 sinuses, the inferior petrosal sinus and sigmoid sinus, which will join together to give rise to internal jugular vein. So there is an inferior petrosal sinus and sigmoid sinus, and 9th, 10th, and 11th nerves are passing through it. So 9th, 10th, 11th nerve, as well as the inferior petrosal and sigmoid sinus. And hypoglossal canal, well, the name says it all. Hypoglossal canal is giving passage to the hypoglossal nerve. So pretty simple and straight question, guys. We know that mandibular nerve is the nerve supplying the muscle of mastication, and mandibular nerve is running through the foramen ovale, which is located in the greater wing of the sphenoid. So instead of asking this question directly, which one is a foramen ovale, which one is foramen lacerum, which one is jugular foramen, they do like this. Like they will give you a question like this is very simple, but they can give you a question like there is a herniation through the foramen ovale. What could be the consequences? And that's why I always suggest that try to read the osteology of the head and neck part at the end, because when you reach the end of the head and neck, you'll be knowing about the foramen, the structures passing through the foramen, what are their function. So just knowing MALE, 4 structures are passing from foramen ovale is not enough at your level. You need to know what mandibular nerve is doing. What is the function of the lesser petrosal nerve? Accessory meningeal artery is coming from where, and what is the job of the artery? so that if a clinical question is also asked on any of these foramen, you should be able to mark them comfortably. And guys, this is INI-CET. Now, you know that these foramen are something which are going to be repeated over and over again. And we know that something in future on this foramen ovale, on the jugular foramen, on the foramen lacerum, they keep on asking these questions. So isn't it wise to kind of read these foramen in more detail, knowing about which bone they're present in, how to identify them from the cranial side and even from the base of the skull? What are the structures passing through them? What is the function of the structures passing through these foramen? And I'm pretty sure that you are basically preparing yourself for the next upcoming exam as well. Moving on, the next question, guys. We said there are a couple of questions from the lower limb. Like one of the questions says, which of the following is not related or attached to the structure marked in the image? Now, again, this arrow mark structure, which is ischial spine, is not asked for the first time in INI-CET. Ischial spine is asked like more than once in the exam, about identification of the structure related to it, about the injury to the nerve present close to this, what is the level of the ischial spine. So they've already asked this question before this INI-CET 3 times about the ischial spine itself in the last 5 to 7 years only. Imagine. I'm not talking about the last 15 years or so. In the last 5 years itself, they've asked the ischial spine thrice. So, well, again, it's our responsibility that we need to identify the ischial spine and read about the ischial spine all we could. Okay. So guys, as we said, the marked structure is a ischial spine, and what ischial spine is doing, it is basically separating the greater and the lesser sciatic notches. You can see there's a greater sciatic notch present above, and there's a lesser sciatic notch which is present below. Now there are multiple structures passing through the greater sciatic notch, like the piriformis muscle. We have superior inferior gluteal nerves and vessels. We've got sciatic nerve. We got posterior cutaneous nerve of thigh. So all these structures are going from the greater sciatic notch. Lesser sciatic notch is also giving passage to the tendon of obturator internus, and it is giving passage to some of the pin structures. Ischial spine, when it comes to the relation, guys, first of all, there is a ligament attached in the ischial spine, because we generally talk about the pin structure related to it. Let's go into more detail. First of all, one of the question asked in the exam earlier was that what is the level of the ischial spine? The ischial spine is present at the level of the coccygeal vertebrae. I'll show in the next image. You can see that the level of the ischial spine is at the level of the coccygeal vertebrae. Tip of the coccyx and ischial spine are at the same level only. The ligament which is attached to the ischial spine is coming from the sacrum, and that is called as a sacrospinous ligament. So there's a ligament coming from the sacrum, and that is attached to the ischial spine. We call it a sacrospinous ligament. The muscle which is originating from the inner aspect of the ischial spine is a ischiococcygis or coccygeus muscle. I'm sure you read about the pelvic diaphragm having 3 parts: pubococcygis, iliococcygis, and ischiococcygis. That ischiococcygis, or simply called as a coccygeus muscle, it originates from the inner aspect of the ischial spine. So that is attachment of the muscle to the ischial spine, origin of the muscle, in fact. And there are 3 structures which are coming out of the greater sciatic notch, and they go into the lesser sciatic notch by winding around this ischial spine. So they're anatomically very, very close to, they're related to the ischial spine, and we call them pin structures. P is the pudendal nerve, I is internal pudendal vessels, and N is a nerve to obturator internus. So the pin structures, P is the pudendal nerve, the nerve which is going to supply the muscles of perineum, internal pudendal vessel which is coming from the anterior division of internal iliac artery, and the nerve to the muscle that is obturator internus muscle, nerve to obturator internus. So falling back to the question said that which of the following is neither related nor attached to the ischial spine. Now we know that pudendal nerve, internal pudendal vessels are there related to it. Ischiococcygis muscle is originating from ischial spine, but the tendon of obturator internus has no relation or attachment to the ischial spine. So from the given option, it's the tendon of obturator externus, or even if the internus is given, that would be the answer to this question, because they are not related to the ischial spine. Yet another question, the second question from the lower limb is also a osteology based question. They've given this pelvic bone from the inferior view. So you can see the sacrum, you can see the hip bone, and now again you can see the ischial spine, guys. And I told you that ischial spine is present at the level of this coccygeal vertebrae. You can see the level of the ischial spine. It is somewhere at the level of the coccygeal vertebrae only. Okay, look at the 4 arrow marked over there. Let's have a discussion on what these arrows are given. What are the structures present over there or attached to them or related to them? And which of those muscle or the structure has a role to play in the extension of the hip as well as the extension of the knee? So the question is extension of the hip as well as the extension of the knee. And this is where people got it wrong. Like some of the people got it wrong because I'll tell you, let me just discuss it, and then I'll tell you why they got it wrong. Now, if you're looking at this pelvic bone from the inferior aspect, guys, we already know about the ischial spine, so we have discussed about it here. Now, this over there is a weight-bearing area of the hip bone, which is called as the ischial tuberosity. And ischial tuberosity is known for giving origin to the hamstring muscles, the semitendinosus, semimembranosus, long head of the only the long head of the biceps femoris, and the hamstring part of adductor magnus. So the ischial tuberosity is giving attachment or origin to these hamstring muscles, that is semitendinosus, semimembranosus, the long head of biceps femoris, and adductor magnus. Hamstring muscles are responsible for they assist in the extension of the hip. So yeah, extension of the hip is one, but they cause the flexion at the knee. That's why if the arrow was placed in the ischial tuberosity, that cannot be the answer to this question, because the hamstring muscles are causing the extension at the hip, but the flexion at the knee joint, not the extension at the knee joint. Now, another arrow which was given is on the outer surface of this iliac bone, and this outer surface of the iliac bone between the posterior and the anterior gluteal line is the origin of the gluteus medius muscle. Gluteus medius muscle is having a bigger origin on the hip bone rather than gluteus maximus. Origin, I'm not saying the size of the muscle. The origin of the gluteus medius is occupying more area on the lateral aspect of the iliac bone, on the gluteal surface of this iliac bone. And the gluteus medius muscle, it is inserted onto the lateral side of the greater trochanter, and the muscle is responsible for the abduction and the internal rotation of the hip joint. And I'm sure you read about this muscle in the Trendelenburg sign and the Trendelenburg test also, that gluteus medius muscle is for the abduction and the internal rotation of the hip. Coming to the fourth option, which was the arrow marked somewhere here. Now, there is a muscle which is originating from the lateral slope of the iliac crest from the posterior side, also from the posterior most portion of this gluteal surface of the hip bone, also from the lateral surface on the posterior aspect of the sacrum, which was a last year question as well, last exam question only, and even from the lateral side of the or lateral surface of the coccygeal vertebrae. Now look at this, guys. This entire highlighted region is the origin for the gluteus maximus muscle, the largest muscle of the human body, the gluteus maximus muscle. The bony origin of gluteus maximus is from the outer slope of the iliac crest from the posterior side, from the posterior surface of the iliac surface, the gluteal surface of the hip bone, from the lateral surface of the sacrum, and even the lateral side of the coccygeal vertebrae. That is the origin of the gluteus maximus. It is also originating from the ligament called as sacrotuberous ligament also. And then this gluteus maximus muscle is inserting onto the femur. There is a tuberosity called as a gluteal tuberosity on femur, and also to the iliotibial band. Now, I'm pretty sure that you all know that gluteus maximus muscle, one of the major function of gluteus maximus muscle is the extension. Now, there's no question about it. Everyone knows that hip extension is the main function of gluteus maximus. But here's the catch. We all know that gluteus maximus muscle is inserted to the iliotibial band also. And through this insertion onto the iliotibial band, when the gluteus maximus muscle contract, it will tout the iliotibial band, and this iliotibial band will maintain the knee in the extended position. So stabilization of the knee in the extended position is done by the iliotibial band, and this iliotibial band is pulled or is made taut by the gluteus maximus muscle. So gluteus maximus is the muscle which directly is causing the extension at the hip joint, and indirectly via iliotibial band is causing the extension at the knee joint here. That is why from the given options 1, 2, 3, and 4, the attachment of the gluteus maximus muscle is somewhere here, and gluteus maximus is the one which is responsible for the extension at the hip and indirectly extension at the knee joint. I'll tell you one of the reason, a couple of reasons the people got it wrong in the exam is because, first of all, when you look at the gluteus maximus muscle, if you have not read it, then generally the perception is the gluteus maximus is having a big origin on the hip bone here, and they generally might go for this area. This big area is not for the gluteus maximus, it is for the medius. More in front of it below is the gluteus minimus, and a small posterior portion of the hip bone is giving origin to the gluteus maximus. So don't expect to see a huge origin of the gluteus maximus on the hip bone, number one. Number two, the people who marked the ischial tuberosity as an answer, they did not read the question well, because the hip extension can be caused by the hamstring muscle, but not the extension at the knee. They're causing the flexion. The hamstring muscles are main knee flexors. So the extension of the hip and extension at the knee, if both are given in the option, then answer would have been the the gluteus maximus, which is option A in the given question. One question from histology was also given, guys. It says which of the following does not have an endocrine component? The 4 slides are given, and it was like which of the following is not having an endocrine component. Now, have you realized one thing, that if you look at the last 4 to 5 year questions of histology, not only INI-CET, even the NEET question also, you will notice one thing, that the questions are pretty basic. I mean, they're not asking anything about the specific cell inside. They're not asking to identify any special stain or anything. They're just giving you the slide and they were asking to identify it here. Usually in the NEET exam, they are like more about lining epithelium. They will give you a picture of the transitional epithelium or something, and they will ask you, okay, where does this kind of epithelium will be seen, and more endocrine glands and the cartilages or the lymphoid system is something which is like, I would say, more into the INI-CET exam. So this time the question was given, the 4 slides were given, and the question was which of the following is not having an endocrine component. Now, the 4 slides that you're looking at, guys, this one, the first slide that you can see over there, you can see the section of the seminiferous tubule present inside. If you see the slide of testis once, I'm sure you will not confuse it with any other slide. So that's a slide of a testis you're looking at. That's a slide of a uterus. You can see this tortuous uterine gland also to be seen inside. You can see this big ovarian follicle to be present. So that's a slide of an ovary. And when you look at this slide, you can see some serous acinus are present, which is a serous acinus present in the parotid gland, because even this lightly stained zone in between, that is the islet of Langerhans, can also be appreciated. So the 4 slides shown to us: the testis, the uterus, the ovary, and the pancreas. Now, we did this, a discussion with the students. Some of the people said ki the spleen was also given in the slide. So let me presume that there are 5 slides. If I say there are 5 slides, although the 4 are given, I know that there were 4 slides given in the option. But let's say if I remove any of these one and I put spleen in front instead of it, then what would be the possible answer in that case scenario? Now, guys, knowing that the 4 slide we have testis, uterus, ovary, and pancreas. Now, let me start with the testis first. Now, we all know that testis, Leydig cells, they secrete the testosterone. Now, testis is something which is having an endocrine function because of the Leydig cells, and they have the sperm which is being secreted from the seminiferous tubule. They're also having an exocrine function also. So it will come under both endocrine and exocrine, although the question was only about the endocrine component. So testis definitely is having an endocrine component. Leydig cells are forming that. Ovary, follicular cells, and the luteal cells, they secrete estrogen and the progesterone. No question about that. Ovary is having an endocrine function. Pancreas, again, pancreas is having an endocrine as well as exocrine function. The serous acinus, which are present, they are obviously the digestive enzymes are released by them, and the islet of Langerhans are the one which are secreting the insulin, the glucagon, the somatostatin, and that tells you there's an endocrine function is there in the pancreas. So clearly it's an endocrine gland. What about the uterus? Now, uterus is not having an endocrine component, though it is hormonally controlled, it is responsive to the hormone, but it is not an endocrine component of its own. But it can have an endocrine component when it is a pregnant uterus. Now, pregnant uterus, the decidua is having an endocrine component. So, guys, I would say that if these were the 4 options given, then uterus was the best answer, which is not having an endocrine component, usually not having an endocrine component, unless we're talking about the decidua. Testis, ovary, and pancreas definitely have it. So from the given 4 options, we definitely will go with the uterus as an answer. But having said that, let's say if the 4th slide, if I remove any of the slide 1, 3, or 4 out of these 4 slides and I put a spleen instead of that, then definitely spleen is a better answer, because uterus, at least in the decidual form, it is having an endocrine component. Spleen is not having an endocrine component. So if the spleen was given in the option, then you go with the spleen. If these were the 4 options given, uterus is the best answer from the given options. One question from the embryology as well. The question says which of the following are correctly matched, and this is not the first time this question is asked. The arch and the pharyngeal arch arteries were asked earlier in the exam as well. So let's have a very quick discussion on what are the pharyngeal arch arteries we have, what these arteries are going to give rise to, and then we'll see that which are correct and which are the incorrect match given in the option. What you're looking at right now on this picture here, this is, let's presume this here is a right side dorsal aorta. This is a left side dorsal aorta. This is the aortic sac. When you look at the cranial component of the heart tube, there is an aortic sac, and you can see there are 2 horns of the aortic sac. That's a right horn of the aortic sac. That is a left horn of the aortic sac. And these horns of the aortic sac are connected to the dorsal aorta by 6 pharyngeal arch arteries. We know that we have 6 pharyngeal arches in the beginning, and every arch is having an artery inside which is connecting these horns of the aortic sac to the dorsal aorta. So we have first arch artery, second arch artery, third, fourth, fifth, and sixth arch artery. Now look, if you look at this aortic sac, now I want all of you to please look at the screen, guys. This is the aortic sac, the left horn of the aortic sac, the left side fourth arch artery, and even a part of the left side dorsal aorta that is contributing into the arch of aorta. Aortic sac, left horn of aortic sac, left fourth arch artery, and left dorsal aorta, part of left dorsal aorta, they're all contributing to the arch of aorta. So if I just keep my focus only on the arch arteries, I can say that left side fourth arch artery is contributing to arch of aorta, right? Right horn of the aortic sac, this right horn of the aortic sac is going to contribute to the brachiocephalic artery. You know, the brachiocephalic artery will go toward the right side, and again it is going to divide into the common carotid and subclavian artery. So the right horn of the aortic sac is going to contribute, or is going to form the brachiocephalic artery. Now, be it right side or left side, the third arch artery. Now, I want you to look at it very carefully, guys. Third arch artery will give rise to the common carotid. There is a bud for the external carotid, and then you'll see it is going to contribute to the part of the internal carotid artery. Now, this is important. The proximal part of the third arch artery, the proximal part of third arch artery is forming the common carotid. Whether it is right side or left side, the proximal part of third arch artery will fall common carotid. External carotid artery is simply coming out as a bud, and the distal part of the third arch artery is contributing to the proximal part of internal carotid artery. It's not the whole internal carotid, because the remaining internal carotid artery is by this dorsal aorta, the one which I'm pointing at right now. This cranial part of the dorsal aorta will contribute to the distal part of the internal, or you can say the distal part of the internal carotid artery. The proximal portion of the internal carotid artery is formed by the distal part of the third arch artery. I repeat again, proximal part of the third arch artery is contributing to common carotid, and distal part of the third arch artery is contributed to the proximal part of internal carotid, because the distal part of the internal carotid is by the dorsal aorta. There is an artery which is called as a seventh cervical intersegmental artery. The right side subclavian artery and left side subclavian artery, there's a huge difference between them. The left subclavian artery is only by the left seventh cervical intersegmental artery. That's it. Left seventh cervical intersegmental artery alone can give rise to a left subclavian artery. But the right subclavian artery is by the right seventh cervical intersegmental. Right fourth arch artery is also required for that. So right fourth arch artery is also needed for this. So it's a big difference between the two. Left subclavian artery only by the left seventh cervical intersegmental. Right subclavian artery is by the right seventh cervical intersegmental, along with the right side fourth arch artery. So fourth arch artery on the left side is contributing to the arch of aorta, whereas the fourth arch artery on the right side will contribute to the subclavian artery, right subclavian artery. Now, with the development of the lungs, the lung buds, these lung buds are invaded by the sixth arch artery. So the proximal part of the sixth arch artery, proximal part, guys, again, mind the proximal distal thing. Proximal part of the sixth arch artery is going to contribute to the pulmonary arteries. Obviously, the lung buds will be invaded by the pulmonary arteries. Whereas the distal part of the left sixth arch artery, only the left, the distal part of the left sixth arch artery is going to give rise to the ductus arteriosus, which obviously after birth will become ligamentum arteriosum. And this also was one of the questions asked in the exam in the previous INI-CET question, that patent ductus arteriosus is because of which artery. Though it's a distal part of the left sixth arch artery. If it is patent even after birth, that will give rise to the patent ductus arteriosus. So guys, these are the main arch arteries which are giving rise to the major arteries in there. You're looking at the arch of aorta and branches and the pulmonary artery. The first arch artery, the remnant of the first arch artery is maxillary artery. The remnant of the second arch artery is stapedial and the hyoid arteries. These are embryonic arteries, the stapedial and the hyoid arteries. Third arch artery is common carotid and the proximal part of the internal carotid, Fourth arch artery, arch of aorta and the right subclavian artery, nothing by the fifth arch. And the sixth arch artery will give rise to the pulmonary artery and the ductus arteriosus. So that is a little discussion on the arch arteries. So now if I take you back to the options, first arch artery, maxillary artery, yeah, it's correct. First arch artery, maxillary artery is a remnant of that. And so is the hyoid and the stapedial artery are the remnant of second arch artery. That is also correct. Third arch artery will give rise to common carotid, correct. but not the distal internal carotid, guys. That is the problem. Distal. It's the proximal part of internal carotid artery which is found by the third arch artery. So that is not correct. If this was given in the option, distal part is given, that was not correct. Sixth arch artery, arch of aorta. No, that is also not correct. Sixth arch artery is for the pulmonary artery. And fourth arch artery, yeah, the right proximal subclavian artery. We know subclavian artery is by the fourth arch artery and seventh cervical intersegmental. So obviously the proximal part of the right subclavian artery is by the right fourth arch artery is also correct. So from these given particular options, 1, 2, and 5 are correct. 1, 2, and 5 are correct. And well, needless to say, guys, this is something I'm not recording this in the recall for the first time. These arch arteries are something which have been asked like earlier many a time. So you cannot in the embryology, specifically in the embryology, the pharyngeal arches, the pharyngeal arch arteries, the arterial development, the cardiovascular system. If you're going for the INI-CET exam, you have to go through this part, because there is, if they're framing a question from embryology, I guess the CVS embryology is the first thing which comes to their mind. Coming to this one more question, guys, and that question is from the upper limb. The question says that it is a question which probably will be discussed with you in your ortho as well. A 7-year-old boy presents with the emergency department after falling on the outstretched hand. The X-ray shows the extension type of supracondylar fracture of the humerus, guys. Supracondylar fracture of the humerus. On examination, he is unable to make a OK sign with thumb and index finger. He cannot make a OK sign. Like there's a weak OK sign is there. He cannot make a OK sign. Which structure is most likely injured in that case? Okay. For that, let's have a very quick discussion on the nerve. So, guys, what you're looking at here, it's a median nerve which we're going to discuss. The median nerve is one which is coming from the lateral as well as medial cord of the brachial plexus. Once the median nerve is formed, the root value being C5, C6, C7, C8, and T1, the median nerve in the arm is not supplying anything. It is the most medial content of the cubital fossa. And then you will see the median nerve is going to pass deep to the flexor retinaculum. It will pass deep to the flexor retinaculum, and then it reaches the hand. So in the arm, median nerve has no supply. Actually, the first supply by the median nerve is a pronator teres muscle only. That is a muscle forming the boundary of the cubital fossa. And then it crosses the flexor retinaculum by passing deep to it. So it is a content of the carpal tunnel. Carpal tunnel syndrome, median nerve can get involved. Let me go in a retrograde fashion, guys. The median nerve in the hand, it is supplying the thenar muscles. Now, when I say thenar muscle, it's the abductor pollicis brevis, flexor pollicis brevis, and opponens pollicis muscle, which are supplied by this, but not adductor pollicis. Adductor pollicis is a muscle of thenar region only, but that is supplied by the ulnar nerve. So the muscular contribution of the median nerve in hand is the thenar muscles except adductor pollicis and the first two lumbrical. The first two lumbrical for the index finger and middle finger, the two lumbricals, the lumbricals which are unipinnate lumbricals. So in the hand, it is supplying the thenar muscles and the lateral two lumbricals except the adductor pollicis muscle. In the forearm, the majority of the muscles in the forearm are supplied by the median nerve. The main median nerve is supplying the superficial muscles like flexor digitorum superficialis, the pronator teres, the flexor carpi radialis, all superficial flexors. But the deep flexors of the forearm are supplied by the branch of median nerve which is called as the anterior interosseous nerve. Now, this anterior interosseous nerve is known for supplying the deep flexors of the anterior compartment of forearm. And when I say deep flexor, I'm talking about the flexor digitorum profundus. But mind it, it's the lateral half of flexor digitorum profundus. So FDS is supplied, flexor digitorum superficial is supplied by the main median nerve. Flexor digitorum profundus, the lateral half of flexor digitorum profundus is supplied by the anterior interosseous nerve. The flexor pollicis longus, the long muscle for the flexion of thumb, flexor pollicis longus, and even the pronator quadratus, which I did not mention here. Now, I want to take your attention to one point, guys. What is the speciality of the flexor digitorum profundus and FPL muscle? Now, flexor digitorum profundus and FPL muscles are the only muscles present in the anterior compartment of forearm, which are reaching the distal phalanx. So, flexor digitorum profundus muscle is going to insert onto the distal phalanx of these fingers, and flexor pollicis longus is also reaching the distal phalanx of the thumb. So if you want to flex the distal phalanx of, let's say, for the index finger or the distal phalanx of the thumb, you have to use the flexor digitorum profundus and FPL muscle, which are supplied by what nerve? Anterior interosseous nerve. Now, knowing this basic about the median nerve, there are obviously more detail into that, but I'm just going to the relevant part. Now, let us say if the median nerve is injured somewhere here, like if the median nerve is injured at the elbow, higher injury of the median nerve, if there is a lower injury of the median nerve like carpal tunnel syndrome, and sometimes the rest of the median nerve works fine. Only anterior introitious nerve is injured. Only anterior introitious nerve is injured. That again could be one of the reasons. Like in the supracondylar fracture, the most commonly injured nerve or most commonly affected part of the median nerve is actually anterior introitious nerve, right? Okay. If the main median nerve is injured, whether higher or lower injury is there, that we know the thenar muscles are gone. Thenar muscles are not working. Opponent's pollicis is not working. There is the abductor pollicis brevis, flexor pollicis brevis is not working. So there will be ape thumb deformity. So whether it is a higher injury or the lower injury of the median nerve, ape thumb deformity is inevitable. You will see the ape thumb deformity for sure. But with ape thumb deformity, let's say if you ask the patient to make a fist, and he's able to make a fist only with these two fingers or maybe with these three fingers, well, it is an indication it is a higher injury. See, if the injury is somewhere here at this point, if the injury is somewhere at this point, what will happen, guys? That ape thumb deformity is there, and because FDS muscle is not working, and lateral half of FDP is also not working, that means there is no flexor for the index finger and maybe for middle finger also not working at all. So these two fingers cannot flex, they cannot make a fist. So while making a fist, either you make a hand like this, the hand of benediction, or it is a pointing index finger. Anything is possible. Pointing index finger or hand of benediction while making a fist. While making a fist, then it is an indication of it's a higher injury. So ape thumb deformity, and you have a pointing index finger or hand of benediction while making a fist, it's an indication of higher injury. If it is a carpal tunnel syndrome, if the nerve is injured in the lower part, that means FDS is working, FDP is working, that means the patient can make a fist. So only ape thumb deformity will be there, but there in the carpal tunnel syndrome, there will be no pointing index finger or there will be no hand of benediction. But here's the case. If the main trunk of the median nerve is working fine, but the anterior introitious nerve is involved, only anterior introitious nerve is involved, then I told you will not be able to flex the distal phalanx of the thumb and even the distal phalanx of this index finger. So you will not be able to make a OK sign like this here. So there will be a weak OK sign here. So more specifically in this question, if the question is asked like which of the following nerve is most likely to get involved, yeah, we have to go with the median nerve as an answer. Though if anterior introitious nerve was given in the option, that is a more specific answer. Anterior introitious nerve is a branch of median nerve only, but in the supracondylar fracture, the nerve which is more commonly affected, directly involvement of the anterior introitious nerve, and that causes this positive OK sign. The patient is not able to make the circular OK with thumb and the index finger. Right, guys? So this is about the discussion on this, the INI-CET recall of the November. The 14 questions that we just discussed, 5 from the, we said from the head and neck, 4 from the neuroanatomy, 2 from the lower limb, 1 from the upper limb, and we had 1 question from the histology part and embryology as well. And as I repeat the same thing which I said in the beginning also, that when it comes to INI-CET, please focus mainly on the previous year questions, because this is not the last time you're looking at these questions. These questions were asked in the exam earlier also. Every single question which was asked in the exam were already asked in the exam earlier. Maybe not in the exact same format, but you know that that's the same topic they're going to repeat. So, I mean, if you're preparing for the INI-CET, which I always say is a more very topic-oriented exam, we know that which topics are their favorites and they're going to ask. If I just, especially if I analyze the last 2-year paper of 23, 24, 25, I would say 3 years, then I don't see much of a difference between the INI-CET and NEET exam. So gone are those days that I'll say, okay, this question is more important for NEET or this is more important for the INI-CET. I'm talking only about the anatomy part. Be it INI-CET or NEET exam, the same topics are equally important. So if you're preparing for INI-CET exam, you have to go through the previous year questions of NEET also and the vice versa. So I hope that you get a great result in this exam. With that, I take your leave. Thank you so much.